Welcome everyone. Welcome to IDM Study Club. I see everybody coming in tonight. Hello out there. You are in for a royal treat. All of you that signed up and came in here, we are going to be with the dental hygiene takeover, and I couldn't think the timing could be any better. Not only how highly educated our dental hygienists, our colleagues that are on here tonight, they're going to be showing that education and that science, what it does take, I say, to be a dental hygienist with all the noise that's been going on. And I couldn't be more proud of these three ladies and just what they have done in their careers, that they're going to be able to share some crucial information with you. But I do want to start with how how kind of this whole started. You're going to get some background information. I met Holly through Dr. Whit Wilkerson. Of course, they were kind of in shared buildings, got to work together as colleagues. And so our paths truly kind of crossed, Holly, is through IDM. You start coming to our seminars, our courses, our symposiums. And what I love is just your heart and your passion. You just jumped all in. You took on saliva testing, and I remember you reaching out to me and being like, I want to learn about this Tannerilla forsythia. I want to know about nitric oxide. And I just love the passion. And I remember saying, do it. You're like, I want to research it. I want to write about it. And that small little seed, that small little interest, I just want to share with the community, turned into something what I want to call mighty, because you ended up writing a paper for RDH Under One Roof. It was on nitric oxide. You met with our colleague like Nathan Bryan, and you just jumped into the research. I know we kind of shared some things. So share with us where that's taken you, because I want other people, one of my missions is everyone to hear, hey, if I can do it, a girl from a small town in Ohio, I always say we all can do it. And that's what this community is really about, to share our love and passion with each other, to raise each other up as a community. And Holly, that's exactly what you've done. You were able to fall back on some of us for support. You made connections throughout our community. So tell us a little bit about that.
Well, I want to thank you, Laura and IDM, for allowing us to take this evening over. It is an honor. I cannot believe that I get the chance to do this and share not only with my friends here tonight, but a bunch of nerdy information. It's so amazing to be able to connect with people who speak the same language and feel the same way and have really interesting curiosities towards different parts of dentistry. And I think it keeps us motivated and passionate. And I remember I had the fortune of being across the hall from Dr. Wilkerson. And so many times during lunch breaks, we would be the last two during lunch just chatting about this and that. And he would come in so pumped and energized. And one of the early airway discussions that we had was him describing, when someone lays back at night and is having apneic events and is grinding and clenching, and he was using his hands to show how the jaw is shifting and to look for, bruxism and wear, and showing videos, and it was just compelling. And I think the more you surround yourself with people like those that are on tonight, that are excited about lots of different things, who knows what little topic you may find completely interesting, where you want to go and study it a little bit more, and you want to do a deeper dive into things like Tannerilla forsythia or nitric oxide. So I think we need to depend on each other. I think we need to kind of use each other's passion for little things and make friends like he does very well. I always tell him he's a collector of brilliant minds. And so we're just tonight allowed to kind of enjoy the evening together in that honor of all of us pursuing education and just feeding off of each other, so to speak, sharing each other's passion for things. Thank you. Thank you.
And I do want to just take a moment. Dr. Wilkerson is not here. So, all of you that do know him, if we could just send out a group prayer. He is in ICU with his grandson tonight, and so he could not be with us. So, I just love to start a little prayer session to send good vibes while we're all on here. I do believe in that power, and they've been through a lot. So, or drop him a quick note just that we're thinking of him. So sorry that he couldn't be here. He sends his love and he knows these girls have got it. So, with that, Holly, I'm going to turn over to you to get us introduced to Alex and Liz and the exciting information for the dental hygiene takeover.
Well, so at the symposium, I attended, was excited to hear all of these great speakers that IDM put together, and I was by myself at a table, and Alex was there in front at a table in front of me, and I'm gonna let her actually finish the story because she tells it better. But through reaching out together, we kind of connected and have our own little study club thanks to IDM. And so, Alex, I'm gonna pass it on to you to start the night.
Hey guys, I'm really excited to be here. Like Holly was saying, her and I met at the symposium. That was like 2023. We were
Mhm.
both the most introverted extroverts you'll ever meet. So we were both sitting by ourselves, and Holly just scooped me up and didn't let me leave that whole weekend. And here we are 2 years later presenting together. And I feel really lucky. I also pulled Liz into this madness that we're about to present to you guys because these are colleagues that I really value. They are why I'm still in hygiene. I think I've tried to leave hygiene like at least 10 times by now, and they keep pulling me back in, and they have really reinvigorated my career. And so I'm really excited to be here tonight. So without further ado, the crowd goes wild, and we're going to shift it into some symbiosis over here. Okay. So what our goals are tonight, we're going to start looking at early intervention of breathing and feeding disorders, especially when it comes to kind of lifetime oral systemic health. So our objectives tonight, we're going to look at a small case study where we're going to identify some early feeding and breathing disorders. We're going to shift it into some disease processes and introduce some pathogenic contributions. We're going to actually learn a lot from Liz. I'm super excited for this portion about airway screenings for early intervention, something I didn't know a lot about until most recently. Then we're going to throw it over to Holly, and she is our bacterial guru. So she's really going to tie this all into bacteria and basically uncover the healing capabilities of kind of symbiotic species. So, Liz, I'm going to have you switch slides for us. Thank you. Liz is also driving everything tonight. So you're going to hear us say next so that she can proceed the slides. But who am I? I'm Alex. I'm just your hygienist and your friend in hygiene. I am very into personal finance. So hygienist just means financially independent hygienist. And I love to advocate for people in our profession just becoming financially independent. After I graduated college, I went back and went to school for dental hygiene. I work part-time as a dental hygienist, and I'm also a part-time steam locomotive engineer. I am lucky enough that I am a GBT provider. I do hold certifications in ozone and diode laser. My office does implement a lot of salivary testing, perio protect, oral probiotics, all the things, right? I am a CE junkie. I love going to CE, but I'm very much so the person that will pay to go to the CE to listen to the experts. I'm an emerging airway guru after all of this as well. But Liz and Holly, I am telling you, in the wise words of Laura Hooper, they are dental nerds. These two are the ones that are going to go to PubMed. They're going to pull the research articles, design the content. These two are really people that are practicing like evidence-based practice. And I'm so excited to share the space with them. I'm going to kind of power through some of my portion so I can give a lot of the floor to them. But let's talk about them really quick because they're great people. Go ahead and next slide, please. This is Liz. She's a little bashful over there, but she also graduated from dental hygiene school with me actually in 2015. We both went to school together. She is a full-time dental hygienist. She works in a perio specialty practice. She is a myologist, so you're going to see a lot of her advanced training in here. She also is a board member on the International Association of Airway Hygienists. I'm going to give her a plug here. She owns an LLC called Root Cause Resolution, and I do want you guys all to go follow her on Instagram because her content is incredible. She is educating dental community about airway. She's reaching across the aisle and really educating other health professionals. And she has great content that I use to help educate my patients. So next slide. Miss Holly Moons, I think almost half this call knows Holly. She has been in the game for 25 years, and she has so much passion. She has held local and state, roles in their associations. She's done national presentations. She's written and published many articles. She is a bacteria freak. I love learning from her, and it just has really changed how I view dental hygiene. Honestly, I dare you all to ask her about the orange chromogenic plaque that she's been working on, because it's fascinating and what she's doing with salivary testing. So you will see her information here. I would also go follow her on Instagram, reach out to her, because she is your best hygiene hype girl. I'm telling you, Holly has saved my career. So as we were designing this presentation tonight, Holly was going to lecture on bacteria, game over. That was no question. Liz, airway, game over. And I was like, I don't know what I'm going to bring to the table. So originally I was going to talk to you guys about ozone practice in hygiene. But it felt a little impostery because I actually don't use ozone anymore. And it's mainly because I switched practices and we just don't have it available. As I was getting ready to show you guys some salivary tests I've been working on, I just didn't feel like I brought a whole lot of new information, because this is such a great community of people. You guys have all seen the shock and awe of salivary testing. And I just didn't have anything else to really say about it, right? But what I didn't realize is in the background, I was building the most life-changing case study that has ever impacted me. So without further ado, we're going to introduce you first to Gigi's journey. So next slide. So I'm calling this a case study that's a little too close to home. Next slide, please. So my objective for this case study is simply just to identify some of the earliest airway signs and symptoms of airway dysfunction. I want you guys to think about how we establish our microbiome and just kind of learn to be your own medical advocate, because sometimes you have to. So in February this year, my husband and I welcomed our first baby. This is Imogene. We call her Gigi. She was born in February by unplanned C-section. So I want you to keep that in the back of your mind through this entire process, okay? She was born 9 pounds, 2 ounces, which puts her in the 97th percentile. Pretty big, right? Why is this important? So I want you to remember that this baby did not have an introduction through the birth canal. So what does that mean? You know, she doesn't have that good bacterial introduction. We also had a very long stalled labor where the baby took on a lot of fluid. And this photo on the left is really hard for me to be able to see, because it was just kind of the start of everything. So next slide. So in the coming week after Gigi made her arrival, we went to our first appointment, which was 4 days after she was born. We had already been discharged. She had dropped down 8 pounds, 2 ounces. So that was an entire pound that she had dropped, and that put her down into the 85th percentile. And then 1 week later, we came back for a weight check, and we were at 7 pounds, 7 ounces, meaning we had dropped all the way to the 50th percentile in just 7 days. So in 7 days, we had lost 1 pound, 9 ounces. We did begin working with an IBCLC, which is an internationally board certified lactation consultant, where we were recommended to start a triple feeding schedule. And we were told this is so that the baby can gain strength to eat. So next slide. We did 24 days of triple feeding. That is for real. I don't know how I made it out alive. But over those 24 days, we did see that Gigi was gaining weight. So next, we got our big gold star and we got to graduate from triple feeding, which felt good in a sense, right? Next slide. But what was happening at home that wasn't being addressed? Even with working with a lactation consultant, we were still seeing Gigi fall asleep immediately at the breast. This was not 2 or 3 minutes after latch. This was immediate. She was having lip blisters and two-tone lips. She was leaking milk from her lips while she was trying to nurse. I was experiencing a lot of pain, misshapen tissue. We were also having a lot of clicking while nursing. Next slide. And then Gigi was not sleeping. It was very minimal sleep, 30 to 40 minutes max before she'd wake up again. We were starting to see mouth breathing, very prominent side preference. She was refusing a pacifier, which as a hygienist, I was like, yes, okay, girl, we don't need that pacifier. What I didn't realize it was because she couldn't hold it. So she wasn't getting that soothing mechanism, and it became very frustrating for her. Next. Some things that became apparent later on that I did not know I should be looking for. She had a lot of tension going on in her body. It kind of walks you through some of these photos. She had a lot of forehead tension that started appearing. She had a very prominent mental crease. And I asked a lot of providers about this mental crease. And what I was told is newborns are born with recessed chins, and that will get better. And so I didn't really know any different. I was like, okay, sure. She also was holding what I call T-Rex arms and raised shoulders. She was very, very, very tight. I thought this was part of the newborn scrunch that everybody talks about, but she never would really relax. So next slide. While we were doing this triple feeding, she was developing a heavy bottle preference because why not? It was a lot easier, right? But she would absolutely guzzle down these bottles of breast milk in 2-3 minutes. So then what would happen? She would start projectile vomiting. She had really severe reflux, distended belly, very colicky behavior. But we were gaining weight, right? So we got our gold star and we could move on. We didn't have to address any other issues. Next slide. So what we were told by our IBCLC is Gigi's learning, I'm learning, so things will get better with time. We were told that Gigi will get stronger and more efficient and most things will subside. And my very favorite was Gigi is gaining weight effectively. That's my favorite. All right, next slide. So the week after we finished triple feeding, we took our very first trip as a family. We went to what's called Economy, which is a great personal finance conference if anyone's interested. But my husband got sick. He got a stuffy nose, and Gigi also got a stuffy nose during this trip. This was her first signs of congestion, which she then never cleared this congestion, which as a hygienist, this should have been a really big sign for me that something else was going on. But that entire trip, she had relentless screaming, completely sleepless nights. And when we came back, her weigh-in was 8 pounds, 12.9 ounces, which 1 week earlier was 8 pounds, 12.8 ounces. So there was very insignificant gain there. And this is when Gigi dropped to the 15th percentile. So I asked if I could borrow a scale and start doing some weighted feeds at home. So that weekend, go ahead, next slide. I call it the 3 days of hell. So this was an entire weekend of weighted feeds with Gigi, but it became abundantly clear that this baby was taking anywhere from 8 mils to 60 mils at any given time, and there was no relief in symptoms whatsoever. So I went back to triple feeding that weekend just to make sure that Gigi was getting enough calories, and she did kind of start to calm down, in which she wasn't screaming the whole time because it turns out she was very hungry. Next slide. This is when I reached out beyond my care team and I texted Liz, who's here with us tonight presenting. I texted Liz and we were planning to meet up on Monday. And what I said is, if you're cool with that, we'll be there. I don't know what to do to help this girl anymore. This home weighted feed thing is crazy. She's taking anywhere from 8 mils to the largest at 60, deteriorating our mental health. And Liz texts back from this photo and said, based on that photo, she is tied. And this was it. I felt like a cinematic movie. Everything started moving in slow motion. The lighting changed. I felt cathartic music start playing. I was so relieved, but also so anxious because what did this mean? Why can't I see that she's tied? What is going on? Like, how did I miss this? It's been 6 weeks of just complete chaos. And how did I miss this? So next, please. Liz, being the great friend, colleague, educator, she went ahead and texted me a whole bunch of resources as to why Gigi was tied. So she was telling me that Gigi was forming more of a bowl, less of a point. We obviously can't elevate to the roof of our mouth. You can go ahead and advance to the next one. And she went ahead and linked a lot of things that I could go on and read more about where this tongue tie was coming from. And she was posteriorly tied, or what they're calling mid-body is kind of what some of the language has changed to. Next slide. So 8 days later, Gigi was at the dentist that we know here in town getting everything released. So she had tongue, lip, and cheek ties released with a CO2 laser. And I only mention that because you can see in the photo on the right what that looks like. And actually the healing process was great. The procedure is very, very quick. She didn't even cry. They bring her back to the consult room, you nurse right away, and everything changed from there on out. So next slide. After the release. So this is day 1 post-op on the left. Gigi's got her arms up. She's completely relaxed, sleeping with her mouth closed. that was just day 1. I didn't do anything. That was just after the release. Day 6, I popped her little mouth open. You can see her tongue is sealed at the roof of her mouth. And that, again, was just day 6 post-op. So this bar graph is just showing you days after the release and how much weight she started gaining immediately, which was incredible, right? Next slide, please. So we started working with a new IBCLC, as you could imagine. So this is her growth chart. What I want to highlight here is how she started in the 97th percentile, and just in 6 weeks, she dropped to the 15th. And everyone was telling me things were getting better, and they clearly weren't, right? It was right there. It also, hold on, my screen just kind of gave me a blurb. So at week 6, which was prior to the release, to the next weigh-in, which was at week 8, Gigi gained 10 ounces on her own. We didn't supplement with any bottles. Nothing else was done except for the release. So that star is representing from when Liz texted me. And then from there on out, we saw a lot of increase in weight. So we're still in the 15th percentile, but we're gaining. And we're truly gaining this time. We're not, falsely inflating our kid and making her puke so much because we're giving her so much breast milk. So next slide. I think these pictures are very telling as well. The picture on the left is Gigi at 5 weeks. So this is pre-release. What you can see, she's obviously mouth breathing. Her coloring, even in this photo, just looks kind of sick, right? She doesn't look very healthy in this photo. She's got her arms just like this. And she just wasn't doing well. On the right side, I just took this photo on Friday. She's 14 weeks old, 7 weeks post-release. You can see her color is back. She's got some cute cheeks. She's definitely more relaxed. She sleeps now. So this was a big deal. And I think just these two side-by-sides, this is not just a baby that's growing. This is a baby that's a lot healthier functionally, which is great. Next slide. We are working with a myologist who's also a licensed massage therapist. She's also a hygienist. So this girl, Taylor, hits the trifecta. I don't know how I got so lucky, but Liz introduced me to her, and she's helping us a lot, just looking at the palate, the tongue position, and we're really monitoring her tension. We also work with a chiropractor who's helping us with side preference and then her neck and hip tension. Our chiropractor put it the best way, that they are just making space for proper development. And I loved that so, so much. So I just kind of want to round it out and talk about what would have happened without proper intervention. If Gigi's tongue position had never been addressed, how would that have affected her growth and development, right? Also, since Gigi, again, was born, C-section, and we were headed towards the path of formula, what would that have done for establishing that oral and gut microbiome? If we're going towards formula that's not generally, a live probiotic in any means, what would that have done for a C-section baby who doesn't have adequate introduction to bacteria and then going to formula? So I'm going to send it over to Liz, and she's really going to kind of hone in on this airway factor.
Hi, everyone. I am Liz, and Alex just went through a very personal story for herself and Gigi and her husband. The really hard part of hearing that story is that Alex is my friend, and I really don't like seeing her struggle through that. But it's not a unique situation. There's a lot of parents that are experiencing similar hardships, and they're not able to find answers for their struggles for their kids of any ages. It's not just infants. So beyond the obvious struggles of eating and growing and sleeping, why does Gigi's journey matter? I'm going to shift a little bit more into talking about the why we care, why we push for answers, why we choose to be here to share our stories. And we need to talk about the early intervention and what it does, how it sets us up for oral and systemic health throughout a lifetime. So to start, we have to know what healthy is. We can't just jump right into what disease is without understanding the healthy side of everything. So there's 3 main parameters that impact health, oral health, and their temperature, pH, and salivary flow. And each of these has optimal ranges. For temperature, there's an optimal range where bacteria can grow and mature. There's optimal pH ranges. That is, if it falls out of that category or out of that range, then it's an indication that a disease process is occurring within the mouth. And salivary flow is important for salivary clearance and the buffering capacity. So changes to these oral parameters are something that we need to be aware of as providers. And when they're disrupted in this symbiotic relationship between the host and its resident microorganisms, is affected, there's an increased risk of disease. The main component driving homeostasis and maintenance of the oral ecosystem is saliva. And saliva does a lot of things. I feel like the group of people listening to this presentation, anything with the IDM, knows all about saliva. We talk about the enzymes and the proteins and other particles and all the functions that it has. There's cleansing properties that help wash away food particles. It helps keep the mouth more moist. So there is lubrication factors. There's antimicrobial properties that help build a barrier against infections. It begins digestion in the mouth. It helps enhance taste, and it encourages cell growth and repair. It is a big component of pH balance for the mouth. It helps neutralize acids through the buffering capacity. Saliva does a lot of stuff, but we also need to know what controls saliva. So when we're looking at the human body, salivation is controlled through the autonomic nervous system, which is what controls the automatic functions of our body that we need to survive, like breathing and our heartbeat. So when there's different parts of the autonomic nervous system that are activated, there's changes to the amount and the consistency of saliva. If we're in our sympathetic nervous system, it's more like the fight or flight response is happening, and it produces a more viscous saliva, and the oral cavity becomes more dry. For the parasympathetic activation, we're in that rest and digest, and it produces a more watery saliva, and it helps us eat and speak easier. And overall, saliva is also a major part of the oral microbiome, which Alex talked about. So this supports the whole body's ability to fight infection. It aids in digestion, and it helps maintain a balance throughout the whole body. The oral microbiome is a big part, and it contributes to the GI microbiome as well. So it's all connected, and it's important to know that changes to oral temperatures, alterations in oral pH, and loss of saliva initiate dysbiosis very quickly. And dysbiosis is an imbalance of the microorganisms within various regions of the mouth and the body. So when we look at the development of the microbiome, like Alex said, it starts at birth. So this is where it goes back to Gigi's unplanned cesarean entrance, I guess is what Alex put it as. When the baby doesn't go through the birth canal, they don't get that initial introduction to microorganisms that help establish the oral microbiome. So the next option would be the breast milk that Alex worked very hard for Gigi to be able to maintain the breastfeeding journey so she can be introduced to that healthy bacterial strain. An interesting fact to me is that the oral microbiome also changes when the first tooth erupts and throughout a lifetime. So it's an ever-changing ecosystem. And as providers, it's something that we should know more about. And Holly will go into this, being able to support the bacterial strains within that ecosystem throughout a patient's lifetime. Another important part of the oral microbiome is the bacterial biofilm, which is a sticky, dense community of bacteria that organizes itself into a protective layer. There's an extracellular matrix that makes it hard to remove, especially in hard to reach areas. In health, this biofilm is composed of commensal or healthy pathogens or bacterial species that are harmless to the host. If it's left undisturbed, the biofilm grows and becomes thicker and proliferation happens. And that's when the pathogenic bacterial species arise. When we look at biofilm, it starts with an acquired pellicle. That's just an ever-present kind of sticky layer on whatever surface within the mouth that the biofilm is going to attach to. When the biofilm is left undisturbed, it goes through different stages and phases of growth and becomes thicker. The part that's most interesting to me is that as biofilm grows and continues to become thicker, the nutrients change, and you have less oxygen available, the nutrients change, the pH mediating effects of saliva change, and there's a bigger promotional growth of different organisms, and it creates this cycle that supports continued dysbiosis. Again, Holly will go into this a little bit more with the bacterial strains, but this idea of a microbial shift happening within the oral cavity dates back a long time. The main one that we know about or that is talked about in hygiene is the Socrates complex of the pathogens. And they're categorized based on their association with disease severity. So overall, as periodontal disease worsens, the periodontal pocket depth increases and biofilm gets thicker. There's less oxygen available, and it promotes the growth or the shift towards more anaerobic pathogens, which are more associated with dysbiosis and disease. From the microbial shift that's happening, we get into an inflammatory response to the localized bacterial infection in the oral cavity. Again, over time, if these dental biofilms are not removed and the inflammatory response continues, then bone loss happens, and that's when periodontal disease occurs. So as dentists or hygienists, we're taught that there is a continuous cyclical rotation between this microbial shift and an inflammatory response and bone loss, which makes periodontal disease harder to manage. Another factor that makes managing periodontal disease challenging is called virulence. Bacterial virulence is characteristics of bacteria and how they're able to evade the host immune response and the defense systems of the body. The chronic nature of periodontal disease is sustained by this bacterial virulence. They're able to mature and proliferate through self-protective mechanisms, which continues the inflammatory response and the bone loss, and it establishes periodontal disease as a lifetime disease process. So now that we just did a really quick refresh on all things biofilm, why do we care about this? What does it have to do with Gigi's journey? When a baby is born with oral dysfunction, whether it's tethered oral tissue or a vaulted palate or both, or they require a feeding tube or anything that interferes with normal oral functions, it begins a process that impacts them for their entire life. We care about oral dysfunction because we want to be able to support these families and these babies as they're growing. We want to be able to improve on their symptoms from the start. And if it goes far beyond the struggles of nursing and weight gain and poor sleep and colic symptoms, if it's left untreated, oral dysfunction creates significant harm. But as providers, we need to know how. So we're also going to dive into the how this causes harm. As a myofunctional therapist, I look at early oral dysfunction as the start of a continuum that results in severe and several comorbidities and secondary side effects that lead to a lifetime of suffering. And this is generally not all providers here, but generally speaking, because we're not making the connections between oral dysfunction and dysfunctional breathing and deficient facial growth and development. Sleep apnea overall is an end-stage disease of this continuum. If it's something that is occurring in our patients, I feel like every patient I see has this on their medical history. It's been normalized, but I'm going to break things down even more and discuss why early oral dysfunction should be addressed to prevent getting to that end stage disease. Again, there's all of these things that begin from infancy, like Alex is experiencing with Gigi, with nursing challenges, potentially failure to thrive, low milk supply, colic symptoms, poor sleep, all of these things. But like Alex was told, they're a baby, they'll figure it out, they're just fine. And most of these infants that start out like this, and it starts pretty young, just like Gigi had, where they start mouth breathing. And just like sleep apnea, mouth breathing has been normalized, but it is we need to be yelling it from the mountaintops. It is not a normal way to breathe. Mouth breathing, however normalized it has become, we are here to educate providers and patients and work towards it being seen as a massive warning sign for dysfunctional breathing and highlighting the subsequent oral and systemic dysfunctions that occur as a result. We're working to increase awareness of the dangers of mouth breathing by discussing how it skips nasal filtration. It leads to a drier oral environment. And we talked about the temperature and pH changes. It promotes development of biofilm because there's less salivary clearance. Overall, it increases the inflammatory pathways that are happening, and it restricts the upper airway further through soft tissue inflammation, and it continues this cycle of more mouth breathing and airway dysfunction. And that was seen when Alex mentioned that Gigi got stuffy and the mouth breathing never went away. Once the cycle begins, it never goes away. So comparing that to nasal breathing, which helps support filtration of air and it humidifies it and it helps maintain these ideal oral and nasal parameters of the ecosystem. As we discussed earlier, maintaining these optimal oral parameters and nasal parameters is what supports a healthy microbiome. So it may seem harmless, but mouth breathing has been correlated with several forms of dysfunction within the body, and it increases risk for several comorbidities. So there's enlarged tonsils and adenoids, chronic ear infections, tooth sensitivity, allergies, GERD, tonsil stones, bedwetting, postnasal drip, chronic cough. The list is never ending. And I feel like I could probably add something to this every day that I see a patient in clinic. I'm like, oh, that's probably also related to mouth breathing. Further, an important part of any ecosystem is the structural environment that it lives in. So with mouth breathing, the physical structure of the oral ecosystem is significantly impacted, and it leads to what in the myo world we call long face syndrome, or it's deficient mid-face growth. So low tongue posture is usually what starts this. It prevents proper growth. The tongue should rest up on the palate like you see in this left image here, and it helps grow the mandible out and forward. So, and it contributes, when that doesn't happen, it contributes to the formation of deviated septum, narrow nasal cavity, limited tongue space, dental crowding. And these physical restrictions also, they just contribute even further to increased resistance of the upper airway because of that deviated septum, narrow nasal passages, dental crowding, all of that. So when we circle all the way back to the biofilm we were talking about, mouth breathing shows up with side effects of increased biofilm formation because of dental crowding. The teeth are lingually inclined. The biofilm becomes protected in these hard to reach areas, and any hygienist or dentist on here knows what I'm talking about. It's where you can't reach these areas in this person's mouth to keep it clean as a provider. You know they're not able to get to it effectively at home. So the biofilm becomes thicker, and there's more pathology that's developing within that biofilm. It also carries risk because there's temperature changes and moisture changes and pH changes that are happening with mouth breathing. So it's just this massive cycle of dysfunction that begins disease processes in the oral cavity and, as we know, in the body as well. So when you see patients mouth breathing, it's never just mouth breathing. This undisturbed biofilm from the malocclusion leads to a microbial shift, dysbiosis. It changes the oral ecosystem, the temperature, the pH, the moisture, and that triggers the local and systemic inflammatory response, and it increases risk for disease, systemic and oral. It is an ongoing cycle of dysfunction that a lot of times is not properly assessed and diagnosed, where the root cause of the oral and systemic side effects, they're not being connected to mouth breathing and oral dysfunction. They're being treated as a completely separate issue. So going back to this continuum of oral dysfunction, mouth breathing is one of the earliest stages. But if we look at this chart as snoring is the only thing between mouth breathing and sleep apnea, snoring seems a little bit more serious, doesn't it? I think it is something that needs to be a massive red flag. Mouth breathing is the precursor to snoring, and we're missing between here all of this. It's not just snoring. There's also a lot of other things going on that we just covered with the mouth breathing that's happening before the patient gets to sleep apnea. So if we start looking at mouth breathing and at snoring as both initial and final warning signs, there's really not much difference between these two images on the continuum of dysfunctional breathing. Once someone has sleep apnea, whether it be mild, moderate, or severe, they've reached end stage disease, and there's a massive impact on systemic health. There's less oxygen uptake, increase in stress hormones, there's dry mouth, there's fragmented sleep, which impacts growth hormone, there's oxidative stress and free radicals, faster aging, and disease progression happens with that. All of us know that, I feel like, in this group of people in this club that we're in here, but it's not common knowledge. So it's on us to help educate these patients. So it's also important to understand that infants and children do not grow out of their dysfunction unless it's treated properly. When it's not treated properly, they grow around it into other forms of dysfunction, and the comorbidities develop very quickly. And often, like I mentioned, these secondary side effects are viewed by traditional medicine as standalone diseases, and they're treated on an individual basis where medications or surgeries or therapies are recommended, when the best treatment would be to work together between medical and dental providers and get to the root cause of it and see what oral dysfunction is contributing to all of these systemic and other side effects that are happening. So early intervention is prevention. Sleep apnea is end-stage disease with chronic inflammation through this downward cycle that begins. There's the next step, the next events that occur are life-threatening comorbidities, such as a heart attack or a stroke, or the life-altering diagnosis of dementia. Again, these things can be prevented by addressing the inflammatory process that begins with mouth breathing. As a provider and a myofunctional therapist, something that I've learned the hard way is that not one person, one provider cannot treat everything. Even with my training and experience in myofunctional therapy, my own children have struggled and required several different forms of medical and dental intervention. So my oldest child right now, he's 5. He did not have tether oral tissue release as a baby. He's in a palatal expander currently because he is a massive mouth breather. And even with this palatal expander in, he's still getting sharp teeth. So the myo mom in me is slowly dying seeing that, but I know that I am doing what I can to help him grow and get rid of his mouth breathing, which has improved since his palatal expander has been placed. My second son, he is 2. He's a little bit of a different case. So he had his tethered oral tissues revised as an infant. We didn't know until he was 2 that he was still being given his pacifier at daycare all day long. So I dropped the pacifier by age 1 in our house. It's a rule that I set before we had kids, and his mouth just kept getting worse and worse. His palate kept getting worse, the crowding, the lingually inclined. And I was like, what is going on? And then I found 7 pacifiers in his cubby at daycare. So those got cut up and thrown away. And I had a nice little chat with the providers at daycare about why we stopped that a year ago. So even though I tried to do my best, sometimes dysfunction still happens. And from there, he will also be getting a palatal expander at some point in his life because his palate is messed up. But on to my third child. She is her own case entirely. She also had her tethered oral tissues revised. That was after we did a formal sleep study. She was diagnosed with moderate sleep apnea at 6 weeks old. I spent the first 3 months of her life sleeping with her on my chest, vertical in a recliner, because she could not lay flat. Even when she was awake, she could not lay flat. She has laryngomalacia, where the cartilage of like around her epiglottis is weak. So even with just normal breathing, the epiglottis would flop down and cover her airway, and she would stop breathing. It happens when she's eating. It happens when I'm holding her. It happens a lot when she's sleeping. So we went to a lot of providers to get a lot of answers. And for her, early intervention was the best thing that I could think of. And I am so glad that I have the background I have in myofunctional therapy, because I knew to keep pushing. Every provider we saw basically said, this happens, this is normal, she'll grow out of it, it'll continue to get worse between 4 and 9 months, and then it kind of just plateaus until about their age 2, and then they'll get better. I'm like, so I'm just supposed to sleep in a chair vertical until my kid's 2? Is that what you're telling me? And there's like, well, her case isn't bad enough to do any surgery. And my question was, what's bad enough? She has moderate sleep apnea. She's not breathing during the day even, but it's worse when she's sleeping. So we went to a children's hospital in town, and the provider told us that every infant has sleep apnea, and her breathing is not bad enough for surgery, and we just have a colicky baby. So me being me, the follow-up of that, I brought in 2 books for this provider. The Tongue Tied by Richard Baxter and the Breathe, Sleep, Thrive by Shireen Lim, and a couple research articles. The provider that I am referring to told me tongue ties are not real. They have no impact on any growth and development at all. So I was open to having a conversation with him about how when we did her release, her tongue tie release and her upper lip tie release, that night she slept through the night on her back independently for the first time in her life for 9 hours straight. Completely life-changing for a family. This was our 3rd kid. We already weren't getting sleep from our other 2, and there was no sleep happening in our house. So to get 9 hours straight of sleep was literally life-changing. And for a provider to tell me that I just have to wait for her to outgrow it is something that I hope no other family has to go through, especially if they don't have the training I have, because I knew to keep looking and I knew what other providers around the area to go to for help. So I know it's a long story. I kind of digress there, but again, it's important for early intervention with all of this. So now that we've talked a lot about the oral microbiome, biofilm, mouth breathing, facial growth and development, sleep apnea, let's put the pieces together a little bit more. Research shows that there is a reciprocal interaction between sleep apnea and oral diseases, meaning they have the ability to make each other worse, and they're often not an independent issue. Again, it's this ongoing cycle of dysfunction. And with sleep apnea, we see a good example of this is that patients that have sleep apnea also have periodontal disease. They have similar systemic responses that are happening. The systemic inflammation brought on by sleep apnea has similar pathways that are able to potentially make worse the bone loss and the tissue loss seen with periodontal inflammation as well. In fact, they have such similar pathways in their systemic reactions that the 2 are hard to find as independent diseases. More than 66% of patients with periodontitis also have sleep apnea. That's amazing to me. The 2 are very connected. Even more, dry mouth is often experienced with patients with sleep apnea for multiple reasons. They have a mouth breathing habit where, again, it gives us that long face syndrome and it restricts the nasal passages, and there's not the mid-face growth that we need. And it leads to mouth breathing. The mouth breathing leads to 42% more water loss when compared to nasal breathing. And then because of the soft tissue enlargement that's happening from the systemic inflammation, there's no nasal breathing, there's no nasal filtration, there's allergies, there's even more systemic inflammation. So again, this massive cycle of dysfunction is happening. There's even more to this. Dry mouth is made worse by the natural physiological cycles of salivation slowing down during sleep. With patients that have sleep apnea, upper airway resistance syndrome, or any form of airway resistance when they're sleeping, they are in a sympathetic nervous system activation. So if you remember from the beginning, that means more viscous saliva. So when they're sleeping, saliva flow is already lower, and then you add in the sympathetic nervous system activation with the viscous saliva, and it decreases that salivary flow even more. Dry mouth is something that is inevitable for patients with sleep apnea, especially when you add on the treatment options for sleep apnea, which the CPAP, it's going to force air into the nasal cavity or the oral cavity. It's going to dry it out. It's going to change that pH and temperature. If they're in an oral appliance and they're not able to get lip seal, then that is going to dry things out as well. It's going to change all of these parameters. So not only does the risk for periodontal disease increase with oral dysfunction and sleep apnea, but the dry mouth associated with those, there's again the changes in temperature and pH, the loss of saliva, there's a loss of salivary clearance and buffering capacity. Food waste isn't being eliminated. The byproducts of food metabolism isn't being eliminated, and the oral environment takes longer to neutralize after an exposure to food or drinking or smoking or just basic lifestyle habits. This cascade of disease and dysbiosis also contributes to cavity formation in a lot of these patients as well. So with the changes that occur within the oral ecosystem as a result of oral dysfunction, One of the big parts of this is that pathologic bacterial species are able to proliferate, and decades of research have shown us the systemic impacts of these pathogens. I know that was a lot of information. The main points to take away here. Overall, oral dysfunction at any age, it initiates and perpetuates a cycle of dysfunction that has both oral and systemic consequences. And identification and treatment of oral dysfunction starts in infancy. As a dental hygienist, as prevention specialists, if we can assist in improving breathing habits, lowering oral biofilm and bacterial loads, decreasing inflammation, and supporting proper facial growth and development, we prevent comorbidities. And by the nature of our job, dental hygienists remove oral pathogens and provide treatment focused on decreasing an inflammatory response. Again, if these oral pathogens are able to spread and grow and they go to sites beyond the oral cavity where systemic inflammation is present from mouth breathing and sleep apnea, comorbidities are then exacerbated. So as healthcare specialists, along with everything we've discussed already, these oral pathogens are something that we need to understand better to know why prevention is best for long-term whole body health. And Holly is the one that knows all about these pathogens. So I am going to throw it over to her. She's going to talk about some key periodontal pathogens and dysbiosis, and take it away, Holly.
Okay, thank you, Liz. So I think this course really flows well because it starts out as Gigi, the infant, if we continue Gigi's journey and take her all the way to what if we start thinking what would have happened had we not seen the signs, had we not acted on the visual cues. And to joke, if no one knows, the three of us, we're all from Omaha. Alex and Liz still live in Omaha. I am outside. I'm in St. Pete, Tampa, but in the Midwest, we share these secrets, and the joke is knee high by the 4th of July for the corn height, or where to get the best pork tenderloin. But in the Midwest, something that we also have are these huge storms that roll in off of the plains, and you can feel the cool air as these storms approach. And if you're out having a picnic, you know, pack up your picnic and move in. You see the wall cloud, the shelf cloud. You look for the signs of storms coming in based on the weather changes. You see the environment, the sky grows dark, the school alarms go off. And so all of these signs and symptoms are things that we all can relate to in dentistry and in Gigi's story. Liz, go ahead. Next one. So the storm that I see in my day or in the operatory is chronic disease. And Liz was talking about treating these diseases, they're not standalone, they come together. And this is a great article from Dr. Sartorius. He was the director of mental and physical health from the WHO for many, many years. And he came up with this article. It was basically predictions of what he feels like chronic disease and comorbidities may look like. And he said, you know, we're prolonging life, but we're not curing disease. So we're living longer, but we're still sick. And the issue is by 2030, all baby boomers will be over the age of 65. So as you look at the patient in the operatory, who is the person you're going to be working on? They're going to be older. So 70 years, I hear all the time from patients that say, no, I don't want to get that bridge. No, I don't want to do that scaling root planing, whatever. No, I'm 70 years old. I'm too old to do that. No, you're not. You might live to 100. And so think about what that person's going to go through the next 3, perhaps decades. If we're lucky to make it to 100 and look as amazing as Dr. Wilkerson's mom did, you know, I hope, one can hope, but who knows? And so in those years, those final decades, we hope that they are full of dignity and that we are enjoying our life. Comorbid diseases have increased. They're not getting smaller, they're getting larger. And the issue is those that are 60 years or older have more than two. More than two is the rule. It's not the exception. And the other scary thing is it's happening at a younger age. As we look at Gigi and Liz and the kids that are having these issues early on anatomically, if we're not recognizing those signs and symptoms, they're going to run into comorbid diseases at a younger age. Next slide, please. So one will worsen the prognosis of all, just like Liz was saying a second ago. They're not standalone diseases, she said. It makes treatment more difficult. And what he said is he's calling for everyone to assume care. Next slide, please. So the CDC, these are just some hard facts on chronic disease. Right now, 6 in 10 have one chronic disease. 4 in 10 have 2 or more. And this sounds absolutely outrageous to me, but 12% have 5 or more chronic diseases at one time. And I had to come up with a list because that seemed kind of outrageous, but when you start to look at arthritis, asthma, bowel diseases, obesity, osteoporosis, it kind of does make sense. And if we add oral diseases, of course, and so oral disease is going to exacerbate other chronic diseases, etc. Let's look at some of the most common chronic diseases here as a list. Heart disease right now is the #1 killer in the US as well as the world. And what's amazing is the American Heart Association every year comes out with their top 8 assessment, their facts on what's the most common risk factors for heart disease and stroke. And nowhere at any point do they put oral disease in there, which is just amazing to me. So if you're going to reduce your risk of heart attack and stroke, oral health is nowhere in that mix. Cancer, the #1 cancer is going to be lung cancer. Chronic lung diseases. In 2019, that was the #1 chronic disease. Alzheimer's disease. This is amazing to me. Neurodegenerative diseases were not anywhere in the top 10 list in 2008. Here we are in 2025. 2 neurodegenerative diseases are on that list now. In 4 decades, we have Alzheimer's and we also have Parkinson's disease. That is huge. It just should be like a big red sign. Diabetes, metabolic, chronic kidney disease, and I had to add off to the side CKM, kidney, it's cardiovascular, kidney, and metabolic syndrome. It's a disease where there are so many at one time, they're just lumping them together in one bucket. So it's just one big disease. Next slide, please. I built us a little schematic sheet to kind of follow the flow of what we're going to be looking at tonight. So we know, thanks to IDM, if you attend these courses, shameless plug, you're going to talk about things like inflammation. You're going to talk about things like airway. You're going to talk about things like TMJ. And they're going to really connect oral and systemic diseases together. So if you haven't attended courses, please do so. But we know the links. There are strong links, strong science that points towards one chronic disease is going to lead to another, and they are intimately related like a spider web. And so down the list as far as bacteria goes for oral disease, and I'm sorry the line's a little faint here, but if you look down, you've got 2 kinds of bacteria, saccharolytic and proteolytic. Those that will break down into cavities, so sugar fermenting bacteria, and then you have protein metabolizing bacteria like Prophromonas gingivalis or Prevotella, literally the bacteria that are choosing your tissue as a fuel source. Next slide, please. What it looks like to us is this right here. So Liz was talking about Sokransky's complex. So in the 70s at Forsyth, Sokransky came up with what he felt was the most aggressive periopathogens, those that caused bone loss, bleeding, etc. And the path he built was this pyramid. And at the top, of course, we've got the 3 in the red complex, the most aggressive, but then in the middle, we have this kind of middle orange species, and down below, maybe some early colonizers, all of them virulent, all of them unique in their own way, but to what degree it depends on the host immune response. So today, Liz, next slide, please. We're going to focus on 2 bacteria specifically, Tannerella forsythia, one of the 3 in the red complex, and Fusobacterium nucleatum, one in the orange complex. And we're going to learn about the partnership that the 2 of them have in leading to periodontal disease. Next slide, please. So here's Fusobacterium nucleatum, orange species. It's a gram-negative, It's an anaerobic, so non-oxygen needing. It's commensal or pathogenic. Depends on the moment, depends on the environment, like Liz was talking about pH, etc., oxygen, etc. FN, its secret weapon. Over thousands of years, it's figured out how to survive, and its best secret weapon is it's sticky. Seems like kind of a silly virulence factor, but when you're the connector from healthy bacteria connected to the tooth to potentially pathogenic bacteria, it's pretty amazing. So this thing not only connects bacteria, it will connect tumors, as we're going to learn here in a moment. It's a high abundant species in the mouth. You'll see it in the gut, and here you see it next to Streptococcus. Streptococcus is probably the most abundant bacteria in the mouth, which I thought was fascinating. Of course, Streptococcus, many different species, but it's the one that's overwhelming in the environment. But you can see it here next to Prophrimonas gingivalis too. So connecting early to late responders. And that bridge species, imagine if you were able to take out the connector, the Red Rover game, if you think. You've got one hand connecting another. And imagine if you break that chain and break that cycle, what you're able to accomplish. It's kind of like that game of Tetris, like up in the corner, like these little communities connecting each other. Next slide, please. So if we are going to, in dentistry, open the door to this technicolor world of medicine, if you want to call it that, if we're in this land of Oz, we need to start thinking in terms of what our role is in the operatory and how we're able to try to control these chronic diseases. Do we have the power to be able to connect the two? Do we have the power to make a difference in Gigi's life, perhaps, if she ended up this way? And when you start to see science roll in that says Fusobacterium nucleatum is a link to colon cancer, that's very frightening. My brother's 45. He had his first colonoscopy the other day. It's another patient today said that the age for colonoscopies is being lowered. Why? Next slide, please. Because FN, I call it a facilitator. It makes things happen. And one of the things that it can do is it can survive passage through the stomach. The stomach acid is supposed to be acidic to help wipe out pathogens. And if we are on things like antacids long term and we start changing the acidity of our gut, then we kind of reduce the ability of our body to be able to fight these pathogens. So some of them may make it through. And so this is a bacteria that loves to link up with others. Again, so here you see FN, PG, TF, and TD, those last three being the upper red complex. They work together. They work as a team and they invade and induce the host response. It damages DNA, drives cancer progression. It coexists in tumors with other bacteria. What does that mean? Well, we know that a tumor is not just made up of cancer cells, it's made up of microbes, healthy cells, cancer cells, and microbes. And tumors are able to metastasize. So when they start linking up with Campylobacter, for example, a very common gut bacteria, and it's hanging out in the gut. Now we've got a new partnership. FN here below and PG, they synergistically create a tumor promoting environment. They bring on chemotherapeutic resistance and poorer patient outcomes. So a patient that has colon cancer and is put on the chemotherapeutics needed to treat it, it's going to prevent chemotherapy from being as effective as it should be. Next slide, please. Not just any colon cancer, young adult colon cancer. The age group from 20 to 34 is on the rise. So we can't look at always the older patient with chronic disease. We have to start thinking younger because we heard earlier that chronic disease is happening and comorbidities are happening at a younger age. So we've got to start talking to our patients about their gut health, colon health. So GI and gut and oral microbiome, these are intimately related one to the other. So we don't know why this is happening. They think that it could be coming from a poor diet. If we start to look at our food source and the food system that we have right now, it's a whole nother conversation. But the nutrients, we're not getting the nutrients that we really are supposed to be getting. Things like dark green leafy vegetables, vitamin C, vitamin E. And I put these pictures off to the side. There are things now called baby chinos. And we've got Starbucks for toddlers, and everyone's drinking food in a cup with a straw, and I think to the airway, and I know there are better straw options out there that help. Liz would know this, to help work myo wise, but we're everything's in a cup. And one of my favorite movies is Wall-E, the Disney movie, and it's the almost prediction of the direction that we're going in. Your breakfast food and dinners in a cup and a straw, and we're not getting any more nutrients. Next slide, please. So if we break down Fusobacterium, the taxonomy, the little nitty-gritty details, the phylum, we've got 5 main phylum in the microbiome. Fusobacteria is one of them. If we go down the list, species-wise, Fusobacterium nucleatum was the one that we were talking about, but if we go into a subspecies, it's called Fusobacterium animalis. And there are tests out there, again, shameless plug here in a second, that can test for Fusobacterium animalis. And why that's important is because even now, there's more research that's pointing towards a further breakdown into something called clades. And there's an article, Nature March of 2024, the Fred Hutchinson Cancer Center. They're finding a subtype of this microbe, and they were examining colorectal cancer tumors from 200 patients. 50% of the cases, this specific subtype was elevated compared to healthy tissues. And they felt like these two strains were so linked closely together. They looked almost identical that it was hard to distinguish them and tell them apart. And so they've broken it into FNA, Fusobacterium animalis, clade 1 and clade 2. And it's the clade 2 that they're finding is really the one that's linked with colon cancer. So it allows us an opportunity to really step in and intercede at this moment. Next slide. So here we've got linked to multiple cancers. So this is one of the ways that it reduces chemotherapeutics and actually inhibits that link. You can see here in the corner it says FAP2. That's one of the adhesion characteristics of FN that allows it to be sticky. Next slide. Tannerilla forsythia, one of the 3 top red complex pathogens. 10 to 1, you will see information about Prophermonas gingivalis all day long. Why? Because you can study it in the lab. Tannerilla forsythia is a weirdo. It is a taxonomic enigma. And this is Ann Tanner, Dr. Ann Tanner, also a scientist up at Forsyth. I don't know what was in the water there, but she found this bacteria acting really strangely, and she couldn't get it to grow in a monoculture. And so she started to do some different things. She found out when she co-streaked it with Fusobacterium nucleatum, it just blossomed. So she recognized there's something that FN was giving to TF to allow it to survive. And what was that relationship? She didn't quite know at the time. But we're going to be learning here that the bacterium TF has actually figured out how to delete genes, and it's evolved to reduce its workload by deleting these genes, and therefore is going to become more of an aggressive scavenger. And it was forced to acquire different enzymatic processes to survive. Next slide, please. I think of TF like this. This is how my brain works. So in Transylvania, there is a citadel, a powerhouse, this fortress that is surrounded by layers and layers of protection so it could survive over hundreds and hundreds of years. And you are seeing the town around it, this healthy town, and I'm sure lots of roads and gateways to get into the city, to bring in, food, resources, supplies, and ways for people to move in and out. And so to me, that reminds me the most of a bacterial cell. So here is Dr. Tanner's Tannerilla forsythia broken down. It is a pathogen that has this sophisticated S layer. Think of it like a carbon fiber, and it's armor, and it's the armor in which it's able to attach to it a lot of different weaponry, so to speak. There's an outer membrane. There's a peptidoglycan layer. That's the inner portion of the cell wall. Think of it like a zipper. There's the plasmic space and then the cytoplasmic membrane inside. So gram-negative bacteria have a very, very tiny peptidoglycan layer versus a gram-positive that has a huge peptidoglycan layer. But it's within all of these little levels that it's able to arm up. And so what is a little bit difficult to see off to the side is a schematic of what the peptidoglycan layer looks like, and it's made up of little sugar residues called glicnac and murnac. And Tannerilla forsythia cannot make a portion of the peptidoglycan layer, the murnac. It's lost the genes to do that. So therefore, it has to go out into the environment to scavenge and hunt and forage for parts and pieces to make its own cell wall. It is the dog underneath the Thanksgiving table looking for scraps of other bacteria. So next slide, please. I asked AI to build this for me, and it did it beautifully because here is my TF castle, and I call this symbiosis towards disease. And the way I see it, you've got this huge fortress gate, you've got the soldiers at the top, that S layer, the carbon fiber, and outside of TF, you're going to see this gorgeous, delicious apple orchard. And it kind of stands out in this gloomy environment. And here we have this vendor collecting apples and ready to take them inside. So to me, TF, along that outer layer, it has something called sialic acid, and it's a sugar residue. So think of it as a fuel source. It decorates the cell wall with these gorgeous apple trees to blend into the actual environment next to human cells. Human cells have this sialic layer, acid layer, and so TF can elude and evade because it's, not this mean castle. It has this, really amazing apple orchard on the outside. So it's kind of hiding incognito. Next slide, please. Who doesn't have an apple orchard? FN. So this is my version that AI built me a little castle for what FN looks like. So FN has no apple orchard. It is kind of dark and gloomy, but you know what it has is it's got a lot of boulders. It has a quarry. And so TF, in my mind, it has all of these sialic acid apples ready to go, ready to be a fuel source. FN needs those apples. It has none. It's going to need that sialic acid to survive. It doesn't have sialidases, the enzymes used to break that down. So TF can share the apples with FN. FN fortunately has, with all these boulders here in the quarry, plenty of ingredients for that peptoglycan layer. So TF is able to regenerate and recreate its cell wall thanks to FN. So it is a very strong, mutually beneficial relationship. Next slide. So here's a case study. If we look at this patient just as a random, female, under the age of 50, history of breast cancer, genetic testing was BRCA negative, but tested polyps positive for the mutation. History of colonoscopies and polyp positive. So this patient has high levels of TF, high levels of FN, and high levels of FA. And we learned earlier that those two bacteriums have this close relationship. And you have a bacteria that's linked with cancer, colon cancer, breast cancer, etc., because of its sticky nature. So when you look at these two together, I want you to think about, what would you recommend to this patient? Is this a patient that you would now look at this saliva test and think a little differently? Would you intervene a little bit faster on behalf of FN because of all that you know now? Next slide, please. So let's talk about symbiosis towards health. And I will probably speed this up a little bit for time because I want to give the ladies time to answer questions. But there is a mutually beneficial relationship, just like there is this ancient way of planting where you've got corn and beans and squash, and each of them giving of each other to support each other. Corn for the height for beans to climb on, squash for the leaf coverage, beans for the nutrients it provides, all three working together. Next slide, please. And do we have a symbiotic relationship with bacteria? Yes, absolutely. We have our own enzymatic processes, but unfortunately, our body does not make enzymes at times that it needs to. And so we need bacteria to do that for us. Next slide. Nitric oxide. This is the enzymatic process that we are going to lean on in order to link up systemic health. And what it is it's an enzymatic breakdown of L-arginine into L-citrulline and nitric oxide. So let's talk about what nitric oxide is quickly. Next slide, please. It's going to have two components. One is created systemically and one is created outside the body. Systemically, internally, endogenously, there are three enzymes. Neuronal NAS, which is in charge mostly of our neurons, and it's going to be linked up with airway, our ability to learn, our ability to sleep, reproductive behavior. It's going to be responsible for our GI and digestion. Next slide, please. The next enzyme that helps to produce nitric oxide is inducible NAS. This is an anti-inflammatory. This is our immune system link up made by macrophages, neutrophils, designed to go out into the body and attack pathogens. Next slide, please. And then the third enzyme that's linked up with endogenous nitric oxide production is endothelial NAS, and this is in charge of things like vasodilation, blood pressure, reducing heart attack and stroke, repairing vessels, insulin secretion, airway tone. Next slide, please. Problem is, as we get older, our ability to make that enzyme to create those systemic benefits is reduced. So as we get older, we take on more oxidative stress and chronic disease. But also what happens is our oxygen levels go down, our pH goes down, we become more acidic. So there's a second backup plan. For us in Florida, we know it as a generator when we have hurricanes come through. And this backup generator is completely dependent on bacteria in the mouth. And it's called the nitrate to nitrite to nitric oxide pathway. Next slide, please. So this is what I consider the Rosetta Stone of nitric oxide. It shows you the schematic of how this is made. So what happens is you eat green leafy veggies, it's swallowed, it goes through the stomach, into the intestines, most of it's lost, some of it's absorbed into the bloodstream. It's brought in through the plasma, which then, like Laura will say, becomes saliva. It's rained onto little bacteria in our mouth, on the tongue, and the bacteria will enzymatically break it down into nitrite, and that becomes nitric oxide. So it's this whole system of us eating green leafy veggies and it going through our system twice, once to break it down, twice for the bacteria to do it, and then it creates this nitric oxide molecule, which then allows us systemic benefits. Next slide, please. So they're learning that the bacteria on our tongue are these nitrate reducing bacteria. And these bacteria are known as Neisseria, Rothia, Veillonella, different species that are responsible for this. So off to the side, I've got schematics of these are images of epithelial cells, again from Forsyth University, where they are able to show you the way that bacteria kind of clump together in teams and communities and how they kind of push each other out almost like a neighborhood or want to be next door to another because of things that it might give. So what is one bacteria's trash is another bacteria's treasure, and the metabolites kind of run the show. It's the way that they are using each other to survive in this environment is not just about one, and it's great when we knock out one, but it is a bigger, broader picture, and that's what I hope to kind of describe tonight. So these are our nitrate reducing bacteria. Next slide, please. The beauty of the bacteria on the tongue is that they have access to a whole bunch of different things like saliva. And so we forget sometimes we've got major saliva glands. But we forget sometimes that there are minor saliva glands. And so as the saliva runs down the tongue, just like this waterfall here, these bacteria are fed and fueled by these nitrates. Next slide, please. So now we've got oral disease and systemic disease. Next slide. And these sugar fermenting and protein fermenting bacteria. And now we can add a whole new category, which is nitrate reducing bacteria. Next slide, please. So we know that these nitrate reducing bacteria are going to connect with blood flow. The systemic connection for us is that every organ and tissue is completely dependent upon the integrity of blood vessels and blood flow. For us in the mouth, it's this photo here. It's the capillaries trying to fuel tissues, a tissue graft that makes it. But if we kind of broaden our view here, our scope, we can see, well, now with the healthy oral bacteria, we can start to really shift systemic health, including the vascular system in general, blood pressure, blood flow, or even airway. We're talking about airway disturbances earlier. Next slide, please. One more time. And so now we've got connections between systemic health. Can we connect oral health? Well, let's keep going. So next slide, please. So oral health associated nitrate reducing bacteria, they are going to be associated with a healthy environment in the mouth. Next slide, please. However, the investigation of these healthy microbial populations, they reveal they are all genera that have been confirmed to be reducing nitrates. Next slide. So of these genera, Rothia and Neisseria are bacteria with the strongest association with nitrate, increasing most, if not in all, studies which oral communities are exposed to nitrate. So we have the research that shows us these healthy commensal or symbiotic bacteria in the mouth are linked towards systemic health. Next slide, please. All right, one more. Can we take it to oral? Can we fill in that next Rosetta Stone for us? Next slide. And we are going to show that here. Next slide, please. So if we go back to sugar fermenting bacteria, we know that they produce lactic acid, thus causing cavities on enamel. Next slide. The coolest thing is that the nitrate reducing bacteria will use the lactic acid as an electron donor for this pathway. So what happens is you have bacteria that are fermenting sugars causing cavities, but the good news is the healthy bacteria are going to use that acid up as an electron donor. That's their fuel. Talk about metabolite exchange. So you've got the control of healthy commensal bacteria in this way to help fight cavities. Next slide, please. Periodontal disease. Can we fight periodontal disease with these healthy bacteria? Well, if we think about periodontal disease, it's not just isolated to the oral cavity. The oral cavity is the beginning of the respiratory system, the GI tract. It's connected to the bloodstream. So we are in charge of the mouth, but it's also everything distal to the mouth. Next slide, please. In addition to systemic benefits, nitrate metabolism by the oral microbiota appears to be an important reviewed. Nitric oxide has antimicrobial properties, killing sensitive species, including anaerobic bacteria associated with periodontitis. Next slide, please. In contrast, representatives of Rothia and Neisseria increase the presence of nitrate are associated with the absence of inflammation. Nitric oxide could also directly signal to epithelial cells, possibly contributing to gingival homeostasis by increasing blood flow, mucus thickness, while decreasing inflammation. This is the point where, Liz, I'm going to have you flip to the last screen because of time. But what we can say is, and keep going to the, thank you. At this point, we're able to connect the dots on this schematic regarding oral systemic connections, periopathogens we're trying to control, cavity bacteria we're trying to control, but we have this new introduction to nitrate reducing bacteria linked with systemic health, linked with oral health, and fighting disease. Next slide, please. And the end. So I want to stop here. I kind of sped through because I want to allow others to ask these amazing ladies questions. Thank you guys. Thank you everyone for hanging in there with us tonight. Sorry we went a little long, but I really appreciate what this group has done. And if you guys don't know anything about IDM, if this is your first study club, please check them out. Please go on the website. Please show up. You will meet all kinds of amazing people and you will learn so much. This will reignite your desire to help others, whether it's yourself or your patients or other teammates. I could not think of a better way to pursue my next couple decades in my career than to be here along these guys and continue to learn and grow and be a part of this. So thank you, Laura. Thank you, Dr. Wilkerson. Thank you, everyone, for joining us. Alex, Liz, amazing. I'm going to turn it back over to you, Laura.
Yeah, it's just so much gratitude. Wow, I had so many takeaways, and I want to get to questions. We only have a couple minutes here, but just huge takeaways, percentages. I just want to say, love the 66% of perio patients have sleep apnea. Just love that you put in there, Liz, structural, microbial, and inflammatory. So many great takeaways there I think we can learn from. I would urge everyone to come back and listen to this again. It is under our study club. All of these are recorded, so you'll be able to share with your teammates. But I do want to ask a few questions. You can decide who's going to take this. The first question was on the relationship between sleep apnea, oral and GI dysbiosis, anatomical abnormalities, and myofunctional therapy. That is a lot, but who would like to take that on? Give us an answer on that relationship.
I'll take that one. I feel like a lot of my presentation kind of connected those, but it goes back to, and I'll try to make it a simple answer. If someone's mouth breathing or has sleep apnea, the oral parameters, the oral environment is going to change. The pH is going to change, the temperature, the salivary flow is going to decrease. There's going to be the structural changes of the crowding and the lingually inclined teeth that make the biofilm harder to remove. So all of that kind of goes together, and then myofunctional therapy is what helps to address all of those issues. So I hope it kind of connected all of it with the presentation that we gave. I think that question was submitted before we presented, so hopefully we were able to answer that.
Perfect. And then the next question people are asking is, what would the steps be for the pediatric patients that they notice are mouth breathers? Since you went through that kind of continuum from, right, babies to mouth breathing to all the way advanced disease sleep apnea, and they ask for adults, but what would those first steps be for patients that they see this in?
Typically I recommend, I always have called it Xlear, but I think it's called Clear. The nasal spray, that's like the top thing that I recommend. It just helps to clear the nasal passageways, get rid of nasal inflammation, and help the patient be able to get back to nasal breathing. If you remember, like Gigi had, she started having inflammation from a cold, and once that, if that never goes away, then she can never nasal breathe again. So I always start with the nasal hygiene. I know some people for adults will talk about mouth taping. It's not generally my favorite thing. I would like people to have a myofunctional assessment first to make sure that they can breathe through their nose before they're taping their mouth shut all night long. Otherwise, they're just going to go into even more sympathetic overdrive with that fight or flight because they're not breathing. So a simple way, I guess you could assess patients' chair side would be to like give them a piece of mouth tape to sample and see if they can nasal breathe effectively and efficiently for at least 3 minutes before they start using mouth tape overnight. But the big one for me is nasal hygiene, either like a neti pod or the Xlear nasal spray, and then kind of go from there, work with the myofunctional therapist. They'll have a lot of recommendations based on the patient needs. once they do the assessment.
Well, we still have more questions coming in. I would urge everyone that you have come back. You have their direct emails and links to submit to them directly, or you can always submit to them here at IDM and we can get that out to them. But I appreciate everyone tonight. We do have our next study club will be August 6th. We'll have Dr. Stephen Carnouston coming on, linking sleep. Yes, sleep disordered breathing. We're going to continue this pathway all the way through TMD and TMJ disorders. So we'll look forward to seeing everyone then. And I thank everyone. Thank you so much, Liz, Alex, for sharing your really heartfelt stories. I was having people text me. The mamas out there are loving you that you guys exposed some of the, what you say, authentic truths that we all go towards. And this you're hearing, this is my tribe. So love it. And Holly bringing it together of right how this affects us and our oral microbiome and our other breathing with nitric oxide. Thank you so much for your knowledge and expertise. Appreciate you. Good night, everyone.